The biggest challenge for current medical students isn't mastering the material, it's developing resilience. Dr. Sateesh Arja, Dean of Avalon University School of Medicine, believes we've gone too far with student-centered learning, leaving many unable to handle failure or receive critical feedback. Dr. Arja's perspective comes from an extraordinary personal journey. Growing up in an underprivileged agricultural family in rural India, he lost his father at just 11 years old. Despite these immense challenges, his academic brilliance earned him admission to one of India's most prestigious medical schools. Today, after completing multiple master's degrees and a PhD from Harvard MGH, he leads one of the few Caribbean medical schools with dual accreditation from both ACCM and CAAM-HP. Under his leadership, Avalon boasts an impressive 75% match rate while maintaining among the lowest tuitions among accredited Caribbean medical schools. In this candid conversation, Dr. Arja shares practical wisdom about overcoming struggles, the importance of mentorship, and why the current generation of students needs a better balance between self-directed learning and faculty guidance to truly succeed in medicine. Dr. Arja, thank you so much for being on the podcast.
Yes, thank you for inviting me for this podcast. Definitely, I would like to share my, the experiences or wisdom, whatever I have gone through for the last 20 years as a medical educator at the Caribbean Medical School. And I'm happy to share my experiences with you today.
Excellent. Well, that's a great segue to my first question, which is, what do you see as the biggest challenges and opportunities in medical education today?
I think the biggest challenge is for the students is to keep up with what you call current trends in medical education, and also facing what you call standardized examinations. That is one of the key challenge that I see with what you call medical schools, even across the Caribbean medical schools. The reason is the current generation, they need to develop what you call resilience. That is one thing which I would like to see in the current generation students is resilience, especially when they have what you call struggles or challenges, whatever they can see, because definitely medical curriculum is a vigorous curriculum and it requires a lot of dedication, passion, self-discipline, and love towards medicine. If they have these things, definitely they can achieve that. But one thing which I would like to encourage the students to have a plan from the day one. What should I be doing every day? They should have a plan. And when they have a plan for the next 4 years in the medical school, and not only having a plan, but definitely implementing that plan in the action, in action is very important. That implementation is very important. And if they have foresight, that because definitely medical school is the biggest challenge, and there will be a lot of struggles and hurdles, but if they have a plan to be successful, definitely they can make it. But there is one thing which I would like to tell the students, that they should have a plan for the next 4 years and work according to your plan. Definitely you should be able to successful, but at the same time they need guidance also, because for that guidance they need to approach the appropriate faculty members and mentors to make sure that they're on the right track and they can give the required tools for the students so the students can be successful. Again, by saying that what you call mentor, the mentor should be a facilitator for the student, not imposing on anything to the students. If we try to impose things on the students as a mentor, it may not work out for the students. We need to see what is the best for the student, what is the best for individual students. According to that, we should have a plan for the student, and we should have a joint plan of action. It's not my intentions on the projecting on the students. It is all about what your student wants, and according to that you need to give the plan of action to the students. If we can do that, definitely the students can be successful under the guidance of medical educators. That's what I see it.
That makes a lot of sense. I mean, obviously having a mentor who's been, who's done it and then also has seen other people do it and then can help you see sort of your blind spots and things that you can't see is definitely an important thing. I'm curious to know more about what you were talking about with resilience. So, if I'm someone that's struggling with resilience, let's say, what are ways in which I would how would I be seeing this in my life?
Yes. To have resilience, first of all, we might have seen a lot of struggles in our life, and you came out of those struggles because of anybody's resilience. But one thing which the student need when they are going through the struggles is the support. you know Either it could be a psychological support, or it could be an emotional support, or it could be a personal support, whatever it is that is required for the student. And if we can provide that kind of psychological support and emotional support to the students, definitely the student will be successful, or he can try to come out of that struggle. And he will learn the resilience through the struggles only. To take my personal life itself, I lost my father when I was 11 years old, I would say that. And I was in the high school. Maybe I was in the seventh grade or sixth grade, something like that. But at that time I don't have any, what you call, I don't have any support, kind of support or emotional support, at least at the school level, because we don't have a psychology counselor or a personal counselors what we see nowadays in medical school or in high school. Definitely we have a lot of personal counselors which can help the students. But if we can provide the right kind of emotional support to the student, if they are going through the struggles, definitely they can make it. But other problem that I see is definitely a lot of what you call the different kinds of media effect on the students, social media effect. And because of this social media effect on the students, the literature says that it has been what you call uh, reducing what you call a lot of attention span for the students because of social media effect. And somewhere I read it, nowadays the attention span for high school students is not even 15 to 30 seconds. And they cannot focus on anything. That is one problem that what we see with the social media. But not only that, we are also at the same time too much student centered education also, and learner centered education, and we are not giving time, or we are not giving that kind of what you call struggle for the students, that they can go through the problems and they can make resilient themselves. That is also what I see could be a problem for the current trend of students. But we should have a good balance. We should be able to provide the resilient, we should be able to provide the emotional support and psychological support to the students so that they can come out of the issues. But at the same time, you should not be what you call too, it should not be like learner is too much depend on the educator. It should not be spoon feeding, or it should not be too much support. Let them struggle through the struggles, and then they can come out of it, and they can make sure that they have enough what you call, they can be enough resilient.
Interesting. So I wanna talk about what you just said about the learner centered, like we're true learner centered. That's a really interesting topic. I wanna pick your brain on that. Before we do that, I just want to make sure that I understand. It sounds like what you're saying is that we like people's sort of like another word for this is I've heard is frustration tolerance. That people's frustration tolerance or the resilience is too low. One way in which we see this in students that we coach for, say, like USMLEs or things like that, is they don't expect it to be like if they run into challenges, they somehow think that there's something wrong with them, right? They maybe inside of them, they've had challenges with standardized tests in the past. And so they are kind of they're kind of looking for confirmation of those things.
Yes.
And so it's like the first time that they get like a disappointing block on their UWorld questions, or the first time that they, get like a low score on like a shelf exam or something like that, they kind of go to pieces. Some people. And so then they don't study for like a couple weeks, or then they don't, it's like it's hard for them to pick themselves up. Is this kind of what it is you're talking about in terms of
Yes,
resilience?
I would say that they are not ready to take up the failure, cope up with the failure, that is also very important. Coping up with the failure, you can have failure, but it is not the end of the world. If some students fails an NDMA CBS examination, that is definitely not the end of the world. And also student failing on a USMLE step 1 is definitely not the end of the world. I have seen so many students with low scores on USMLE step 1 are able to get into residency. There are students who fail on USMLE step 1 are able to get into residency. But what is more important for them is that what I have learned from this, that's the most important thing. Lesson for me from out of this situation. And if they can try to rectify those weaknesses, then it's absolutely fine. But the most important thing is not having enough self-awareness, thinking too much of what you call assessing themselves in a wrong way, or you can call it as imposter syndrome, whatever it is. And sometimes they expect too much of themselves. That could be also a problem. You realize yourself, and what are your strengths and what are your weaknesses. You should enforce or enhance the strengths as a student, and also you should rectify the weaknesses, with the help of what you call facilitators or mentors or tutors, whatever you call it as. You can definitely rectify the weakness. And if you can do that, not estimating yourself too much, but you identify your weaknesses and then talk to the mentor or talk to the tutor and rectify those weaknesses. One thing I will tell during the orientation all the time: if you want to walk alone, yes, you can definitely walk certain miles. But if you want to walk along with other people using their experiences, like experience of the medical educators or fact members, you can walk long way. Is journey is long. Medical journey is a long one. It's not definitely a short journey. So definitely you need help, and you need a team, and you need companions, you need fellow colleagues or the students. You should work in a team. Then definitely you can make anything that can be happening. You can make it happen in the medical field.
I love it. Yeah, it's like the phrase, if you want to go fast, go alone. If you want to go far, go with others.
Bonus.
I
Yes.
love it. I love it. So I want to return to the topic of learner centered. Can you just define for like let's say that I was a 5-year-old and I don't understand what that means. Like what was like what does being learner centered mean? And then what does it mean to be too learner centered?
Learner centered means the education need to be self-directed learning. That is for sure. Because self-directed learning and self-regulated learning are the most important key areas for the what you call higher education. Because in higher education, self-directed learning and also self-regulated learning are the key areas. Yeah, definitely, in the medical curriculum, what we say is, the teaching methods such as problem-based learning or maybe team-based learning, or if you are using what you call case-based learning, you are promoting self-directed learning. For sure, we are promoting self-directed. For that purpose, what they do is they identify their own learning objectives. According to their own learning object, they work on it, and they come up with a solution, or they come up with a synthesis or some kind of knowledge information. They come up with that, and they share among the colleagues and peers, and that's how you learn. That's what we call it as self-directed learning. And in self-regulated learning, the student assess themselves. They can give their feedback on their own performance or on their own learning process. Not just performance on the assessment, even on their own learning process, they can have their own assessment. Maybe I'm doing well, or maybe I'm not doing well. Based on what you call your self-assessment, you can regulate your learning process. Not just what you call self-directed learning, but you're also controlling your own learning process. Maybe I need to do more that, maybe I need to do less of this. I need to enhance my what you call these kind of what you call learning methods. I should be able to what you call implement more. These are all things come under self-regulated. There is this fine line of difference between self-directed learning and self what you call what should I say, self-regulated learning. But this all two modalities is more towards what you call learner centered education. It's all about learner. They decide what they want to learn. They decide what learning objectives should be there. They decide on what should I do. They should decide what you call what are my strengths and weaknesses. But along with this, maybe we should attach a little bit of what you call the support from the faculty member, the support from the facilitators, the capacity to listen to the others, because this is also another key area. So if they can listen to the mentors, and if they can listen to the tutors and the faculty mentors and educators, they can do much better actually. But what is lacking in the current, not lacking, but I'm not blaming the generation or something like that. It's not about generational issue for sure, because there are many good students. There are many what you call students who are struggling. Our intention is to only to help the students who are not doing well. That is only our intention. There is nothing else. But at the same time, is very intolerant. Some of the students are very intolerant to the feedback. They are not in a position to receive the feedback also. And you can see some students say that they don't care what you say, whatever the feedback that you give, they may not mind about it. But there are some students who think that they know everything, because especially what you call mature students and older students, they think that they know everything, they don't need to depend on your feedback. And it's very difficult for people who doesn't listen to you, or who doesn't care about your feedback, who don't mind about your feedback. It's very difficult for you to handle them. But if they have that capacity to listen, because when you become a physician, or when you are entering into the medical school, the first thing that we ask from the medical students is that, are you a good listener? That's what we are looking for. Yeah, because these all things ties together. If you're a good listener, you're ready to take the feedback, and then you if you are a good listener and if you are ready to take the feedback, the next step is how to implement that feedback. Definitely your teacher or mentor, whatever you call it, as a facilitator. Nowadays, teacher is not a teacher, he's a facilitator. He's only facilitating the learning process. We try to impart the knowledge in students, but trying to impart only the knowledge to the students, those days are gone. Now we are acting as facilitator. Knowledge is available everywhere. Knowledge is available on the internet too. You don't need to give only the knowledge to the students, but you should give skills to the students how to use that knowledge. That is the key. How to apply that knowledge in your clinical practice, how to apply that knowledge in the real world. That is the most important thing here. And then attitudes, definitely professional attitudes, our communication skills, our interpersonal skills. These are the skills that we need to impart in the students, or maybe the students learn these things by looking at the what you call mentor, or by looking at the faculty member, or by looking at the clinician. They learn them from them. It's like all kind of like role modeling. We should be a role model, especially when you are imparting the skills such as motor skills or communication skills or interpersonal skills, whatever it is. This is what I learned as a teacher for the last 20 years. I feel like knowledge is there, but what we need to teach them, how to use that knowledge, how to use that knowledge for problem solving and critical thinking. These are the things that we can impart into the students. That would be great as a teacher.
Interesting. So it sounds like student-centered learning is kind of like so we've got the student-directed learning and then the student-regulated, or the learner sort of regulated learning, and that's kind of combined. So it's the student-directed learning, if I understand this correctly, is kind of like the what, right? It's like, what should I learn? What are my objectives? What are the things that I should sort of take away by the end of this? And then the student regulated part is kind of like the how. It's like, how am I going to get there? How am I going to get sort of feedback, to like track my own progress? Is that a fair?
Yes, definitely. To track the own progress. Self-directed learning, to tell you to be frank with you, self-directed learning is a modality of what you call learning process. It's a pedagogy, like a pedagogy. Is it TBL? It could be PBL, or it could be anything else. But in self-regulated learning, you are not only learning, but you are assessing yourself also. Like what we do in the formative feedback. For example, in formative feedback, me as an educator, I give feedback to the students. And I will give my opinion regarding the students about his strengths and weaknesses. But I will also discuss with the student, in his opinion or in her opinion, what are her strengths and weaknesses. Also, I will discuss with the student. So students is going to tell me what are his strengths and weaknesses. This is what happens in the formative feedback, right? But the same way in self-regulated learning, student can assess themselves and they can think what are their strengths and what are their weaknesses. Based on that, they can regulate their own learning process. That's what we call it as self-regulated learning.
And so when you say that there's sort of too much student-centered learning, or we've kind of gone too far in that direction, it sounds like what you're saying, if I understand this, is that students just like they've taken it to the extreme, where it's like they're kind of they're not listening to any sort of outside perspectives. They think like, I am going to just go it alone. Like, I've lived long enough. Like, I've done this. I know it works for me.
There should be a balance. What I meant to say is there should be a balance between what you call between self-regulated learning and the role of a faculty member in the learning process. There should be a balance. I don't know what is that balance. Is it 50-50 or 75-25? I'm not sure about that. But there should be student-centered learning only. It should be student-centered learning only. But there should be a role for what you call faculty member as a facilitator in the learning process. If they can allow or accommodate the faculty involvement in the self-regulated learning, then it works out.
What do you tell a student that, because we get this a lot, that says like, I don't know how to study. Like, I just don't know, like, I don't know what works for me. And like, I want you to just tell me what I should do when I wake up. Like, I'd like to just know, like, have a plan for my entire day of what it is that I should be doing.
Because this is one of the topics that I cover in my orientation to the new students, like different learning strategies, because you see, not everyone or not every medical school is interested in teaching these kind of skills for the new students. And some schools are doing it. They call it as study skills. I think they are, some schools teach learning theories also to the students, to the medical students, because that's a good practice, especially teaching learning theories and learning strategies, different learning strategies to the medical students is a good practice. But what I teach for them is very simple. You are going for a class for today, for example. Today I need to spend at least 4 to 5 hours. I have to read my information, or I have to work on these things for at least 4 to 5 hours. How do I spend these 4 hours? 2 hours will spend in reviewing the materials that I read from today, that I have been done in the classroom. 2 hours I will spend for the materials, whatever I learned from today's class, I will review them once. But the other 2 hours I will spend on preparing myself for tomorrow's class, for what you call pre-reading assignments, whatever you call it as. Some people call pre-reading assignments, some people call it as what you call for the purpose of flipped classroom, or whatever it is. But I'm going to prepare for tomorrow's class for another 2 hours. This is how I suggest for the student. This is the simple strategy. There is no mantra, there is no magic stick. In medical school, all you need to do is 4 to 5 hours, 2 hours for today's class, whatever I have learned from the class today, and 2 hours for pre-reading assignments for tomorrow. This is what I suggest for the students. But apart from this, there are many other modalities of what you call teaching for the students, or for the learning for the student. You have to do any material that you take, you have to do the repeated readings, multiple readings. That is the basic fundamental principle. And you have to do every information or every topic at least 4 to 5 times. These repeated readings will help you with what you call retention of the memory and retrieval of the memory also. It will help. But how you space it, it depends on the student. For example, if I am doing what you call one reading for tomorrow's class today, that is my first reading. Then my second reading happens next day, because I finished that topic in the classroom and again I will review. That is my second reading. Probably my third reading for that topic will happen 2 weeks before the examination, because that topic is covered. And fourth reading will be the day before, or maybe 2 days before the examination. So there will be 3 to 4 readings. This is what you call repeated readings. This is not something which I am telling new, but it's already there in the literature, that multiple readings will help with the students. Then next is what you call practice. What should I practice? Practice the questions. Whatever you learn from the topics, you should be able to practice the questions. As I mentioned to you before, for a medical student, they need to spend 4 to 5 hours a day. Apart from that, they have Saturday and Sunday also, which is weekend for them. But of course, they need to have some social life also. They can spend one day or a half day with their social lives, but they can practice questions. But not only practicing questions, but repeated assessments. You can do your own assessments from different Q banks. I don't need to mention the names of different Q banks, but there are different Q banks available. The students can select any Q bank that they would like to use. They have to do the repeated assessments. This repeated assessments has already been shown that what you call, they have impact on retention of memory and also retrieval of the memory. And that I tested in my curriculum itself. I did it. And we try to implement multiple formative assessments in a human structure and function course. And we have seen a tremendous improvement in the what you call in the improvement in the performance of the students because of multiple formative assessments. Since it was very effective for human structure and function course, we implemented across the courses in basic science curriculum. So these repeated assessments are definitely helping the students with what we call, definitely with the retention of memory and retrieval of memory. These are the different techniques.
So I
Okay.
want to return to that topic because that's a very interesting. That's something that
Okay,
is very
I
near and dear.
just want to finish the topic. Is definitely multiple readings, practice with the practice questions, repeated assessments will help the students. But I also tell the students, when you read something or when you say it, summarize it. Don't keep it yourself, but put it in writing or write somewhere or maybe type. You can summarize it and highlight the important keys. And repeated assessments, repeated practice is important. The reason is the literature says that whatever we teach in the classroom as a teaching, the students can retain up to what you call maybe 20%, not more than that. And if the students are involved in what you call using that information for practice purposes, like maybe practice questions or assessments, repeated assessment, they can retain up to 50%. And if they can demonstrate the same thing, demonstration means in the laboratory examinations or maybe in the labs or clinical skills lab, whatever it is, if they can demonstrate it, they can retain up to 70%. It is shown literature, already shown that. And if the student can teach the same to the fellow colleagues or peers, they can retain up to 90%. So these are the what you call different techniques that we teach the students on the first day of the class in during our orientation. Hopefully, these things will work out for the students.
So if I understand correctly, I mean, I mean, the principles of good learning are kind of like universal. So
Yes.
you got to learn it. You got to learn it well in the first place, right? So that's sort of the pre-reading and then going to class. You have to have a system for retaining it. So this is, I think, what you were talking about with the repeated readings. Like, make sure that you got the pre-reading, you've got the reading on the same day that you just did the class, and then maybe like a couple times before you take the test.
Sure.
So that's the retention part. There's the application part or the practice part, where it's like you're taking advantage of the testing effect by using question banks or other sorts of practice materials. And then you have to make sure that it's working, right? Like, you got to assess and see, like, over time, like, am I seeing my scores actually get better? Is that right?
Definitely. Yes. Yes.
I love it. Yeah, makes total sense. That's exactly what we found as well. I wish I'd had this conversation with you, 10 years ago, but yeah, that makes a lot of sense.
This is what I learned from my PhD, one of my coursework also. It is the theoretical implications of learning. You know, this is one of the coursework. This is what they teach, the cognitive learning, neuroscience of learning, and everything. And it makes sense to me. Because it is applicable to the students and it is effective for some of the students.
I want to talk about like making it successful for all of the students, making it applicable to all of the students. And I think you started to talk about this earlier when you were saying that some people just are closed to feedback. My thought when you said that was actually something earlier that you'd said, which was like, people's resilience is low. Like, I think that I wonder if maybe there is a correlation between those two things, where it's like, if my resilience is low, if my frustration tolerance is low, then when someone tells me something that's discordant with what I'm doing, someone is essentially telling me what I'm doing is wrong or should be modified, then it's easy to see how someone could see that as like a psychological attack and then sort of put up their barriers. Is that?
Yes, definitely. That is one of the factor which plays a role, because nobody is interested or nobody is ready to take negative feedback for sure. But I don't blame only the learner on that part. The problem is from both sides. The problem is both sides. Why? Because when you give the feedback, the first thing is, if you start with weakness or if you start the areas of improvement, definitely they will be not interested in knowing it. But you start with strengths. You start with what you call giving, but it need not to be sugar coated. You don't need to do the sugar coated. Whatever it is there on the assessment, it is there. It's a factual, it is evidence based, it is data based, and everything you see on the what you call your result. But at the same time, I don't want to jump on something what you call only negative feedback. I want to start with positive feedback, then comes the negative feedback. The other problem that I see with the feedback is, most of the times the feedback given by the faculty members is vague. It's not useful to the student. And if you are not what you call, if you are not giving a specific feedback, if you say that you need to read more, that is very vague feedback. And you need to work harder, you need to read the textbook, people say like that kind of stuff. But that is very vague feedback. But you need to be very specific feedback, which area exactly from the assessment or from the test the student is weak. And not only telling the student that what area they are weak or they have area what you call maybe they need to improve, but you should give them the plan of action and corrective information. Sometimes the students may not have corrective information, they might be using the wrong resources. So you as a faculty member, you should be able to provide them the corrective information and the right resource to the students and joint plan of action. You always should have what you call kind of what should I say, apologetic behavior for the students. Maybe some students may have barriers for their success, barriers for their learning process. There might be some hurdles. You need to identify what are those barriers or hurdles, and you should support the student in that way. If the student feels that my feedback is valuable, it helps me in my learning process, definitely they will listen to us. But if not, and then the problem is there from the faculty side or from the teacher side also. Problem is on both sides. Nowadays, Some students are very reluctant to receive the feedback or to take the feedback, and some students even don't show up to receive the feedback also. There are a couple of incidences, I would say that, where even students don't show up for receiving feedback. But if we can give what you call valuable feedback to the students, and if they think that this feedback is very specific, it can help me in the future to make me better in the next examination or in the next assessment or maybe in the learning process, if it helps, the student will definitely will come to our feedback. And if the student realize that value, yes, you can change that circumstance very easily between the students.
I mean, that sounds like a perfect system. If you've got teachers that can identify what students' blind spots are, like what is your, help me figure out if I'm an overwhelmed student, like what's my biggest problem that's holding me back, and then give me kind of like a feedback sandwich where I tell you not just what you need to change, but also what you're doing well, kind of build you up and say like, hey, this is really great.
You
And
see,
then give very specific and actionable feedback, and then show results, right? So it's like the student can see like, oh, this improved my learning immediately, or this improved my scores. And then of course they would come back. Is that,
yes,
and be open to feedback. Is that what I'm hearing?
for this, faculty development is the key.
So talk to me about this, because this is something that I find fascinating. I have had many conversations with people at institutions at all level, including my alma mater, where these are not their words, but these are kind of my words. In just hearing it from these individuals, it's faculty development kind of it seems like it's like herding cats, because it's like sometimes I see these really gifted educators where they're like, they know what they want to see done. And then it's like, you have to, it's like,
We started giving faculty development activities to our faculty, I would say, since last 10 years. I became the dean in 2016. We started doing faculty development activities for this school. Since 2015, we started, I believe, for faculty development activities. We continued. We give on a regular basis. It's not sporadic faculty development. Every semester, we have a couple of faculty development activities. You name it. For example, giving effective feedback to the students. That is one of our faculty development activity last semester. And what you call psychological safety of students in learning environment. Tomorrow also we have emotional intelligence, because these are all important topics. Because you may have clinicians who are teaching the medical students, but they are clinicians. They are not meant to be educator or teacher. It's not an inherent thing. But I know physicians can be able to pass on their information or their knowledge to the next generation of physicians. But definitely, for sure, they can pass on that information or pass on that knowledge or pass on that skill. But what is important for them is to know is how effectively they can do that. That's what I see in faculty development activities. And not only that, but we also, for example, biomedical scientists, they are meant for as a biomedical educator or biomedical scientist, but they need to be an effective teacher too. If they are teaching the medical students or if they are teaching any professional students, they need to be effective teachers. For that purpose, they need definitely faculty development activities. What we focused, 4 areas we focused of faculty development. We do different faculty development, of course we do it, but we have identified 4 areas. Teaching methods is one of that area where we train our faculty mentors in different contemporary and versatile teaching methods. Not just the contemporary, but versatile teaching methods. Because versatile teaching methods or maybe multiple teaching methods are more effective for the students. And then the second area that we focused on for faculty development is assessments, giving effective assessment to the students, because assessment drives the curriculum. We all know about it. So we teach the teachers about what you call giving effective assessment. Third area that we have a look at is what you call research, medical education research. Because it's not only about them doing different methods, but if they can publish few papers and if they can learn something from current literature and they can implement that in their education model, that's why we focused on medical education research also. The fourth area that what we have seen for effective faculty development, or the topic that what we identified is delivering effective feedback to the students and maintaining that student-teacher relationship. No mistreatment in the learning environment. Students should be respected. That's what you call it as a psychological safety. And the best learning environment, providing the best learning environment for the students. These are the 4 areas that we kind of focused on the last 10 years.
What sorts of results have you seen from this? Like,
I would
have you I'm sure you track metrics or things like that.
definitely, because I would say that definitely I can boast on this. The thing is that most of the faculty members that we have, for example, in basic science faculty, they have implemented their these kind of practices in their teaching methods. They have implemented it, which we can see when we attend their classes, and we can see that reflection on the course evaluations. Students talk about it, so it has shown effective that teachers started implementing or doing implementation of what you call those teaching methods and assessment methods in their daily practice. It's happening. It happened and it's happening. It will happen also. That's what we see. But the other thing is the teachers also can advance themselves in the professional career. And one way of that advancement that I have seen in us, among our faculty is that they apply to different fellowships in education. We have a higher education fellowship from UK. We have Academy of Medical Educators fellowship from UK. IMSC Medical Educator Fellowship from US, and Amy. I think you might know Amy also. Amy Educator Fellowship is also there. Fellowship is there. At least more than 50% of our faculty members in the basic science have at least one of those fellowships. So more than 50%, I would say, in our basic science faculty. So that's what it speaks, that we are able to implement these faculty development activities. The teachers and students are getting benefit out of it, and it is reflecting on the success or achievements of our faculty members also.
I mean, it sounds actually very similar to what it is that you were talking about before about, student success, right? It's like you got to learn the thing, you got to remember the thing, you got to practice the thing, and then you got to assess
Same
the
thing is
thing,
faculty
right?
development.
It's
Same thing is faculty development.
the
It's
same
not,
thing. That makes
yeah,
sense.
you attend a webinar. Okay, for example, a faculty attends a webinar, a faculty attends a workshop. What is the use of it? What is the outcome of it? The only outcome that I can see is that, yeah, they should be able to implement that in their practice, in teaching or assessment, whatever it is. They should be able to implement it. But not only implementing it, but the outcomes should be better. The outcomes of students, students' performance on assessment. That is one of the outcome. Definitely, other outcome is course evaluations and clerkship evaluations. These are the different outcomes that we can talk. And it has shown that it is improving student performance on assessments, and also it has shown that what you call our course evaluations and clerkship will keep improving every semester rather than going backwards.
Wow, that sounds great. That sounds, yeah. I mean, it's funny because like I'll talk to people at a lot of other medical schools, and one of the most common things that I hear is that faculty complain that they just don't have enough time, or they don't have the training, or they're pulled in other directions, right?
Yes.
Because if I'm a clinician and I'm paid, mainly my salary is mainly based off of my RVUs, then
Fellowship,
it's
yeah.
very difficult for me to devote the time necessary to be an effective educator or be a more effective educator.
Yeah. If the faculty complain of what you call time or buying time, if there is a complaint, then we can work it out. But if they are reluctant to learn, then this is a problem. That is something which is very difficult to change.
I want to hear more about your own personal journey. So you went to one of the top medical schools, a very, very competitive medical school in India,
Yes.
and you did very well from our conversation off camera on the USMLEs. And my understanding is that you went directly to being a faculty member at a school rather than go to residency, say like in the United States. Can you walk me through your thought process for that?
Yes, definitely. Because it's not that I didn't go for residency, but I tried for residency for sure. I applied for residency for a couple of years, and I got interviews too. But probably I might not have done well in the what you call well in the interviews, because my communication skills now is completely different from what I had like 15, 20 years back. Definitely I might not have done well on interviews, but this is one thing which make me wondering always. But still, I do what you call counseling for the students for residency application process and residency interview process. Students contact me more than anyone else on campus regarding career counseling and career guidance and residency application process. And I'm the one who implemented mock residency interviews for our school. Of course, there are other people involved in mock residency interviews, but I am the first one to what you call start this mock residency because I looked at other schools, especially American medical schools. They are doing mock residency interviews, and it helps the students. Mock residency. It has shown that it helps the students a lot. And I did the most mock interviews from my school last year and this year too. Last year I did 23 interviews last year, and this year I did 30 interviews this season. Students are getting benefit out of my mock interviews. I think they're asking me, different questions. They're asking me with different kinds of help. I'm ready to help them anytime. Sometimes students ask for mock interview out of 5 o'clock, after 5 o'clock. I will never say no for them. Students ask for mock interview on weekends also, and because of their busy schedule with clinical rotations and all those things, or maybe busy schedule with the interviews, I will never say no for it. I'm always there for my students. But coming to my journey as a residency, definitely, how can I help the students myself who is not able to get into residency? I think you learn few things from a successful story, right? Definitely you learn certain things. But if somebody tried for it and if they don't get into residency and if they can find something interesting, definitely that will be helpful to them more than from a successful man. The reason is because they can tell you what you should do, but I can tell them what they should not do.
I love it. That's it's funny. That was going to be one of my next questions. So let's just go there.
Yeah,
One of my favorite techniques
yeah.
in
But what happened? I have to complete the. Definitely, I have to tell this story to you. But I applied for 2 years. After applying for 2 years, because obviously, application for residency is not a simple thing. It is involved with money. Definitely it is financial. As I told you about my story at the beginning of interview itself, I'm not from a rich family background. I lost my father at the age of 11, and our family is agricultural family from very rural background from India. Even though I am academically successful, but I came from very rural family background. And because of that background or because of financial circumstances, after continuing 2 years, I felt like I may not be able to afford for residency application on the interview process. Then I started thinking about what you call, at that time I already in the job purpose. And then after that, I did 2 masters. I completed 2 masters, as you know it. And I completed PhD from MGH Institute, Boston, Massachusetts General Hospital, one of the best institute for research in US. I finished PhD over there, and I have quite extensive publications in medical education, more than 30 publications in medical education, apart from biomedical publications. Uh, and why I'm saying this, and also I have 4 fellowships in medical education, but from different organizations. I have fellowship from AME, which is International Association of Medical Education in Europe. And I have one from Academy of Medical Educators from UK, that also I have. And I have principal fellowship from Advanced Higher Education Academy UK and fellowship from International Association of Medical Science Educators from US. After working for 2 years to get into residency, I decided to stop my what you call pursuing residency over there, and I stopped it. But I completely went into academics, but it motivated me to be in academics full time. Somehow after a couple of years, the only thing is, once we get the match results and all those things, students send me what you call hundreds of testimonials. Every year I get 10 to 20 testimonials from the students, and I put it on my notice board in my office. Always I keep it on my notice board in office. This year 10 testimonials, next year maybe 10 to 20 testimonials. And that kind of motivates me. As I said before also, the student success is ultimate pride for me, my student success. And that motivated me, and I decided to be a complete academician. But by the way, I took oath recently to practice as a family physician on the island also. But still, I'm not intended to practice as a full-time practitioner, but I definitely would like to continue as academician, and I see my life, my rest of my life also in the academic field only.
Wow, that is a beautiful story. I hadn't put all those pieces together. So you Wow. So you've lived what you were saying before about resilience, right? Like you've lived that.
Yes,
You
I learned.
lost your father at a very young age. Grew up in a very, like a much less developed part of the
Yes,
country, of a much less developed part of the world.
definitely, I would say underprivileged area. I would say that very less developed community, and it's very difficult to have facilities they over there. A government or you can say public school, public high school, and the more than what you call underdeveloped community or underdeveloped area. But have seen a lot of what you call financial struggles, as a student, and that puts me on top of it when a student struggle with financial issues at our university. Whenever a student comes to me with a financial struggle and they need financial scholarship, if they want to approach an educator in the campus, they approach me, because obviously, if they have financial struggles and financial scholarship, the first person they should go to is bursar and then the finance department. But some of the students will also approach me if I can give a word to the finance committee on behalf of the student. I never denied any student so far that I will never talk to the finance department. I always talk to the finance department, whether it is what you call a reasonable request or whether it is unreasonable request. But I present on behalf of the student. Whether the finance committee agrees for it or not, it is up to them and up to their bylaws and regulations. But generously, our finance department and the both vice presidents are and even the president also are very generous in helping the students, especially when the students are academically good and financially struggling.
There's a couple, man, there's like so much rich material to draw from. I One of my favorite techniques to use for figuring out how to be successful is exactly what it is that you described, which is that if you can ask, like, how could I be successful in an interview, right? How could I match successfully? But that will get you only so far. Actually, a better technique is to use inversion, which is to say, what could I do that would mean that I wouldn't get in, like that I wouldn't, like I wouldn't get an interview, or I wouldn't get into residency, and just do the opposite. And so, you know, for that reason, I think that oftentimes the people, like, I was never a good test taker when I was growing up. So I
Yeah.
struggled a lot with those things. And so I had to teach myself and learn from others, and right, how to be a much better test taker. And so I think because of that, it makes it a lot easier for me to teach other people, because I've had to struggle through every one of those steps. And it sounds like nothing was handed to you, so you had to struggle through all of these steps. And so because of that, you're able to guide people more effectively, and in their own journeys.
Yes, definitely. Because the one thing which I learned from my own journey to be in residency is, as I told you, that I applied for a couple of years and I didn't apply for the third year. I should have done third year and fourth year too. This is again persistence and perseverance. And this is one thing which the students also should know, that even if they don't get into residency for the first year, don't give up. And even if you don't get into residence in second year, don't give up. That is one thing which we have to teach the student. That kind of resilience, persistence, and perseverance is the key for if you want to become a physician. Because those three are very important qualities. We always talk about what you call self-discipline in medicine. We always talk about passion for medicine. But what is important for a medical student, even for him as a person, is definitely is persistence, perseverance, and don't give up. And you have to have resilience. You have to be resilient throughout your journey. These are the three things that we need to inculcate in students starting from first semester. We need, it's not I am inculcating in them, but I should be able to teach, or maybe I should be able to what you call talk to them, freely. These are the things that could happen. Don't give up at any point of time. But coming to what you call interview, specifically for interview, I know that I'm a shy person. I used to be a shy person, definitely. And that is not good for any interview taking skills. But I learned doing interviews from because of my interviews with the students. Because I have done interviews for the admissions committee between 2015 and 17. So I worked for admission committee. I did many interviews during that period for the prospective students. I learned what you call great deal amount, what you call amount of what you call this skill from those kind of interviews when I did the admission interviews for the students between 2015 and 17. And again, I'm learning now from 2021. I think we started mock residency interviews for these residency applicants starting from 2021. This is almost 2025. For the last 4 or 5 years, I'm doing mock interviews. That also helped me to improve my own interview skills. And built on all these things, the suggestions that we give for the students is very simple. What suggestions and what they should not be giving. For example, the first important question of any program that you go for, the first question should be, tell me about yourself. We all know about it. But when you ask them to tell me about yourself, the students speak for 5 minutes or 6 minutes. But as I told you before, how much attention span the interviewer has on you, it may not be even 30 seconds or 60 seconds. So don't talk about yourself for 5 minutes, 90 seconds, maximum 90 seconds or 2 minutes. You start with your family background, 1 or 2 sentences about your family background, then academic experiences, your bachelor's degree and MD degree, couple of sentences, 1 sentence for your basic sciences, 1 sentence for your clinical rotations, then work experience and research experience. These are the things that you need to speak. Everything is like 2 sentences, 8 to 10 sentences. You should be able to finish in 90 seconds. They got everything of you, they know everything of you. Don't tell me again why I want to become a doctor, why I want to choose only internal medicine specialty. These things will come up later. Or you might have already mentioned in your personal statement why you want to become a doctor. You already mentioned in your personal statement. They might have read your personal statement. Don't repeat the things which are redundant. Right? Definitely, you need to be very focused on those things. And for every question that we have in residency interview, there is a specific way of answering questions. That's what we teach the students during our mock residency interviews.
That's awesome. That's like gold. How do you deal? That is such a common question of
Because, for
like,
example, the last question will be, for example, in the residency interview, the last question is, what questions do you have for the program? Don't ask the silly questions. Don't ask the questions for the information which is already there on the website. It's a golden rule because it's already there on the website. If you ask the same question, then it looks like that you didn't do enough research about the program. And don't ask irrelevant questions also. It's very important. So these simple principles that what we teach in the mock interviews and the feedback that we got from the students who got mock interviews is tremendously what you call uniform statement. That is very useful for them for the residency interview process. Because we give feedback to the student after every question. That is the unique thing about our mock residency interviews or our mock residency interview program. Yeah, but not only that, because of my experience in the educational field, and academic field, I already explained you what I have gone through my academic journey. But I'm doing even site visit for the accreditation body for the Caribbean medical schools. CAMHP is the Caribbean Accreditation Authority for Medicine and Health Professions and all those things. If they have any site visits, it's a voluntary work. You don't need to be mandatory. But if they have any site visits, and if they think that I am deemed fit for that, what you call school, they will ask me or they will invite me. Then I go for it. I did 5 site visits for CAMHP so far, and it's ongoing. And also, I worked for 1 site visit for World Federation of Medical Education, also WSMA. Also, I did 1 site visit for them.
So this is actually, it's like a perfect segue because this is where I wanted to go next. Accreditation is something that most med students don't think about until there is a problem. Can you walk me through in the simplest way, how does accreditation work?
Because accreditation, you see, in 2012, I think in 2012, ECFMG announced their policy. The policy that they announced is starting from 2023, any student who is applying for ECFMG certificate or sitting for USMLE Step 1 and Step 2 examinations must be coming from a medical school which is accredited. But not only that is accredited, but that accreditation body should be recognized by WFME. This is what they stated in 2012. But now, recently, they have changed their stance and they have changed their policy. And now they are saying that even though you are coming from non-accredited medical schools, but you can sit for USMLE Step 1 and Step 2. You can still be ECFMD certified. But what will happen is we will inform the program directors whether your school is accredited or not accredited.
Was that recent?
Yeah, that started in 2024.
Oh, I see. Okay.
For example, you are a program director. You have 10 students from different medical schools. 5 students are coming from accredited medical schools and 5 students are coming from non-accredited medical schools. What would you prefer? It's very simple, right? So that is how it works. And not only that, they said that that accreditation bodies should recognized by WFME. For Caribbean region, the accreditation bodies which are recognized by WFME are ACCM, which is Accreditation Commission on Colleges of Medicine from Ireland, and also Caribbean Accreditation Authority for Medicine and Other Health Professions Education. That is CAMHB. These are the two bodies which are recognized by WFME for the Caribbean region. But of course,
Is there any statistics around people's acceptance rate for residency or match rate for residency if they come from a accredited school versus not an accredited school?
I think this is a pretty new thing which started in 2024. Maybe
Sure,
we
I guess.
should have data going forward because this is very recently updated. Not only letting the program director know about the accreditation status of the medical school, but even if you go to the World Director of Medical Schools, there is a website called World Director of Medical Schools where the schools are listed. And if you go on to the information related to that medical school, whether that medical school is accredited or not accredited, it is shown on the World Director medical schools also, because it's and I'm sure a program director must think in that way. I should take or I should consider the students coming from accredited medical schools rather than from non-accredited. I'm not undermining any education or training from non-accredited medical school, but if the school is accredited by a proper appropriate accreditation body, it shows that the school has quality teaching, quality education, quality training, and it assures the quality assurance of the school. That's the reason why I prefer or I would recommend is that the program directors should consider the accreditation status of the medical school. But you see, as I told you, it is nothing to do with what you call nothing to do with the educational training, but it makes sure that it assures that the educational training is appropriate from an accredited medical school.
How common is it for a school to lose accreditation? Because I've heard of Caribbean schools losing accreditation.
It's very difficult for the schools to lose accreditation unless you are not keeping update with what you call update with the progress reports required for the accreditation bodies.
So, so in other words, you got to be doing some pretty awful things to lose your accreditation.
Yes, you need to be doing very pretty awful to lose the accreditation. To gain accreditation is difficult thing, but to lose the accreditation, you must be doing something stupid. And there are a couple of schools which I know that at least there are 3-4 schools I know that in the Caribbean region, they lost accreditation, but they might not be following up with what accreditation bodies are asking for. Because once you get the accreditation, they don't leave you. You need to submit the annual reports. You need to submit the annual data. You need to submit the annual progress report. If you don't keep up with that, then you might lose the accreditation. But by the way, in the Caribbean region, there are 80 medical schools in the Caribbean region, 80. But out of 80 medical schools, there are only 15 medical schools which are accredited. So you have to be careful, as a prospective students. Anyone who is applying for Caribbean medical schools, they need to be thinking, am I applying for an accredited medical school or not? They should be thinking in that direction.
If you don't have accreditation, what happens? Is there like a negative consequence, like to the students?
Negative consequence means just I told you that there is no guarantee for education or training. There is no quality assurance is in process. But negative thing, as I told you, that if the graduate is applying for residency, the program directors might look at the accreditation status of the school. If I am the program director, my thinking is that should I take a student from accredited medical school or non-accredited medical school? Definitely, obviously, you will think that I should take a student from accredited medical school.
Is there a list of the 15 accredited Caribbean medical schools out of the 80?
Yes, it is there. If you go to the CAMHP website, these CAMHP website, what you call updated the list of the list of schools which are accredited. And if you go to the ACCM website, They also have updated the list of schools which are accredited by ACCM. So the list is updated. It is not even 15 medical schools if you exclude University of West Indies, because University of West Indies is a public funded school, and it's not a private medical school, but there are private medical schools in the Caribbean region, around 80 medical schools. But out of that 80, I won't see more than 15 which are accredited.
All right,
And by the way, our university, Avalon University School of Medicine, is accredited by both ACCM and CAMH. It is accredited by both accreditation bodies. We are one among what you call the Caribbean medical schools, which has accreditation from both ACCM and CAMH.
Oh, I see. Wow. Okay.
Yeah, ACCM actually has given accreditation for us for 6 years, and CAMHP has given accreditation for us 4 years. And this is the maximum number of years can be given by ACCM and CAMHP. We are the only medical school in the Caribbean which is accredited by ACCM and CAMHP for the maximum number of years.
If I'm considering, let's say I'm a high school or undergraduate college student, and I'm considering going to Avalon versus other Caribbean schools, what would you tell me?
Definitely, I would definitely will say that you should consider Avalon because it's an accredited medical school and it is doubly accredited medical school.
What are you able to share like statistics of like passing rate for USMLEs and for match?
For our school, yes, our USMLE step 1 pass rate is around 80%. Okay. And step 2 pass rate is above 90% for the last 2 years. Last year and this year, step 2 CK is above 90%. Our match rate is around 75%. So there is nothing, what you call, I would say, to hide here. Everything is transparent. Last year, I think around 60 students applied for residency. Out of 60 students, 46 students got residency, which is close to 75%.
Wow. And one thing that students always are looking at when they are looking at schools is attrition rate. So like, just getting to the point. So 80% step 1 pass rate is actually pretty high. But how many students, like of the students that like enter in? So like if there is say 100 students that enter in.
Your question is very straightforward. I would say that our attrition rate is anywhere between 10 to 20%. Sometimes you may have attrition high, but sometimes you may have low attrition some years. But our attrition rate is anywhere between 10 to 20%.
And that's over all 4 years of medical school. Like meaning like if 100 students join, then maybe 80% will graduate.
Yeah, of course it will graduate. Because I will give you this scenario, 2021, 22, that academic year, our attrition is around 15%. And 22, 23, our attrition is around 22%. And 23, 24, our attrition rate is 11%. Last year it was 11%. 11% attrition is very common. Attrition, the problem with attrition is up to 25% is reasonable for any school. Attrition rate, 25%, which is acceptable. Even if you take a class of 50 students, not forget about the attrition. Pass fail on one course also. If 75% of the class passes the course, it is okay. But if the failure rate is more than 25% in that class, in that course, which is not good for any course, that means something wrong with the course.
What does it take for like what are the reasons what are the most common reasons for attrition?
I'm not sure because I have not, as I told you, so far our attrition rate is reasonable. I don't see any humongous or exuberant attrition from Avalon. As I told you, our attrition is far beyond 20%. So I don't see much reason for the students, because one of the reason could be what you call the accelerated programs in the Caribbean, because they finish the program in 4 years and all those things. But if you can give what you call self-study time for the students, and if you can mentor the students, and if you can provide the student support services, appropriate student support services, you can minimize or you can mitigate the risk of what you call attrition. And I think we have discussed last week or maybe somewhere else, the support services that we provide to the students. We have academic advising system, because starting from semester 1, the academic advising system is in place. And then we have what you call a peer tutoring program. We have faculty mentorship program. We have student mentoring program. We have psychology counseling services on campus. We have health services on campus. We have campus nurse who can provide the what you call health facilities and all those things. We can help with the health facilities on the campus. So these are the different kind of student support services. If you can provide student support services, especially academic advising, faculty mentoring, and career counseling. If you can provide these three, along with the psychology counseling and health services, you can mitigate the risk of attrition. You see, we are very committed for the support of the students. We are very committed for the safety and well-being of the students. You can see our motto that we start taking care of the students starting from picking up the student from the airport, because these are international students. They need that kind of help. So we start from there until the time they graduate and they get into residency. We keep in what you call providing them safety and well-being, whatever is required for the students. We do that. And not only that, even if students enter into residency also, we keep in touch with them. As alumni of Avalon, we send emails, phone calls to those students who are already graduated, what they're doing, how far they're in their career, have they gotten their license, are they practicing somewhere. We keep in touch with them and we take the feedback from them. And feedback is, along with student support services that we have, the feedback is the ultimate key for us. We take feedback from students in the form of course evaluations and clerkship evaluations. We take the feedback from the graduates and they give very valuable feedback for us. We use that feedback from the graduates and we take the feedback from faculty members, annual feedback from the faculty members. That also helps us to improve our services, to improve our educational program, to improve our curriculum. So we take the feedback from faculty annually. That also helps us. And what should I say? What is the other feedback that we have? We do biannual surveys for the entire program. That survey is coming from either accreditation bodies such as CAMHP or the survey coming from ACCM. We distribute these annual surveys, biannual surveys, to all the basic science students and clinical students. We ask their opinions on starting from curriculum, teaching methods, student support services, health services, library quality, the dean's accessibility to the dean's office. Everything is included in these services. So those surveys coming from accreditation bodies from ACCM and CAMHP for every 2 years also help us, what you call, in improving ourselves. These surveys, if you look at the results and mean values for us, they're always creeping up, not going downwards for any of the item.
That's
And
beautiful. How
actually, we
much?
published one paper on that. Did the student satisfaction rates at Avalon correlate with accreditation site visits? It is published in Medical Teacher.
Oh, that's
So
great.
you can have a look at it and you can see how these biannual surveys help us with improving our program, either quality wise or any format.
How much is tuition at Avalon for a year?
I think our tuition fee is mentioned in our website and everybody can look at it. And I think the tuition fee for basic science is around, I would say, $10,000. But for clinicals, the tuition fee is around $13,000 per semester. But you know that our tuition fee, if you include everything, it comes around $130,000 to $140,000, and for 4 years. But I could say that our tuition fee is the lowest tuition fee among the accredited medical schools in the Caribbean. And if you go to a big medical school in the Caribbean, like big wigs in the in the Caribbean region, our tuition fee, is very less. Maybe their tuition fee is double or triple to us, or even American medical school tuition fee could be double to triple to us.
I think you're being conservative. I paid in 2009. I mean, the all-in fee, I got scholarships, but the all-in fee for Stanford was 100,000. That's like 60,000 of tuition, and I think about 40,000 for cost of living in the Bay Area. So
Yeah.
that was for 1 year.
How much is it?
It was like $100,000 for 1 year.
Yeah, that means it's close to $400,000 for 4 years, right?
Oh yeah,
Yeah, but for us, it's $140,000
for 4 years,
for 4 years.
including living costs.
No, I'm not including living cost. I'm talking about only the tuition fee.
Oh, I see. Yeah, tuition I think was like 240 for 4
Yeah,
years.
that's what I'm
That's like
saying. The tuition fee for the big medical schools in the Caribbean region or even the American medical schools, currently they are double to us or maybe triple to us, some of the schools. But we want to keep it reasonably well, and we are okay with that.
How do students pay for it? Just loans?
They have loans. Some people pay from pocket. They have loans. They have loans for US students. They have loans for Canadian students. So they have it.
What percentage of students come from the US versus Canada versus?
Because we have 45% of students coming from US and 25% of students coming from Canada. Maybe 20% of students come from India and 10% of students from African countries. I would say 70% of students coming from North America, including US and Canada.
I see.
Out of that, 70%, maybe 45% from US and 25% from Canada.
And people are eligible for federal loans?
No, we don't have federal loans. At this point, we don't have federal loans, but we do have private loans for US citizens.
Oh, private loans for US
Yeah,
citizens.
that's our target, to apply for federal loans. We already in the process.
I see. Oh, interesting. What does it take to qualify for federal loans?
Federal loans, we need to apply for NCFMEA, that is called National Commission for Foreign Medical Education of Americas. We need to submit our application, but the government should submit application on behalf of us. And we submitted our application in 2022. And whenever it comes on their agenda, then we will present. We are hoping it may come on agenda maybe this year or next year, but I'm not sure about that because NCFMEA takes time to keep it on agenda once they receive the application. That's what we are waiting for.
What Caribbean medical schools are sort of or can get federal loans? Do others?
I'm sorry?
Are other how many Caribbean medical schools do get federal loans or
I think
qualify
maybe
for?
there are 7 or 8 schools
I see.
because these are schools which are established long back.
I see.
So we got the full accreditation in 2022. In 2022, we got the full accreditation. Even then, before that, we have accreditation. What do you call that? Provisional accreditation in 2019, and 2022 we got full accreditation. Once we got the full accreditation in 22, we submitted our application to NCFMEA. So because one of the requirements for submitting application for NCFMEA is full accreditation, so we submitted our application. We are waiting for them to keep on their agenda. That's all.
And in getting federal loans, like being able to get a federal loans, what will that allow you to do?
Because the students can get federal loans.
I see. Is it hard for some students to get private loans?
We have submitted our application even for New York approval also. For that also we submitted our application. And we had a site visit for New York approval. We may hear from New York approval maybe in May or June somewhere. I think in June we should be able to hear from them.
I see. Awesome. Well, thank you so much for your time. This has been a fantastic interview. I have learned so much, and I'm sure that other people who watch this later will as well. If people want to follow you or learn more about you, what would be the best ways for them to do that?
I think they can follow me on Facebook. I have my account on Facebook. I have account on LinkedIn, and also I have account on Twitter. I do very regularly. I'm not a big social media person, but I do updates everything on my LinkedIn and Twitter.
Awesome. Well, thank you so much.
I learned a lot from Twitter. One of the program director, I still remember, one of my student is going there for an interview. He follows me on Twitter, and he sent me a message saying that I follow your messages on what you call the posts on Twitter. And one of your student applied for your program, our program. What do you think about her? He asked me that question. So definitely, obviously, it will be helpful in some ways.
Yeah, that's awesome. Yeah, you can promote your students via social media. That's a wonderful dean of
yes.
dean.
I always tell them to be on LinkedIn for sure. Yes,
Awesome.
I encourage them to use. Thank you so much, Dr. Palmerton, for this opportunity. And it's very nice talking to you, and I learned many things from you.
I hope you found Dr. Arja's insights valuable. Up next, we'll speak with Dr. Daniel Sadawi-Kanefka, Program Director at Harvard MGH Anesthesiology, who reveals how program signals can increase your interview chances by over 50%. So click here to discover insider strategies that could dramatically impact your residency match success.